welcome to the program Standpoint on the station that adds value to society, NTA. I am Ngozi Imokwede and the program is Standpoint. My guest is a certified radiologist with over 20 years experience. He has a proven track record in radiology practical, departmental administration and strategic healthcare management, head of clinical services and training, chairman medical advisory committee from 2014 to 2017. From 2017 till date is the MD of the Federal Medical Center. I have with me in the studio Dr. Victor Azubike Osiatuma. Welcome, sir.
Thank you so much.
It's a pleasure having you here.
Thank you. I'm happy to be here.
Did you really went to school to study radiology, or it was JAM that gave you what you decided to study? Can you lighten it?
Well, good morning, viewers. You don't study radiology as your first degree. Okay. I did MBBS. Okay. I'm a medical doctor. Okay. So after MBBS, you go and specialize. Radiology is a specialty for postgraduate studies. So I had my fellowship of the National Postgraduate Medical College in radiology, and I'm also a fellow of the International College of Surgeons.
Okay, you're welcome. With a total budget size of 49.774 trillion naira, the expected allocation for health based on this benchmark would amount to 7.46 trillion naira. The proposed health allocation is 2.56 trillion naira, leaving a funding gap of 4.8 trillion naira. With the funding in place, yet citizens visit hospitals and most times they don't get the required health care they seek for. Why? With all these fundings in place.
Well, healthcare is expensive, and that's why even around the world, no government can fund healthcare holistically, 100%. And that's why you see governments sometimes call for the private sector to collaborate in providing health to our people. Healthcare is expensive, and when you talk about healthcare financing, in most advanced countries of the world, it's through insurance, because nobody can pay out of pocket for health expenses, no matter how rich you are. It is an expensive venture. And so funding of the health sector has not been at its best until recently. When COVID came, it became apparent to us, everybody, the state in which our hospitals were. And the government saw that the hospitals had a lot of gap in terms of equipment, in terms of infrastructure, in terms of room manpower. And so since that time till now, government has started to look into the health sector critically and has tried to provide. It will take years to make up for those gaps. But right now, I think the government is doing a lot to make sure they provide for health sector. So our funding has increased. They're providing more personnel for health now. We have more budgetary provision for capital and overhead. And so I believe if this is done and sustained over time, and our hospitals will be places that we can all be proud to visit.
So assuming we never had the visit of COVID, governments or the stakeholders will not have known that there is a gap in the healthcare sector. Is that what it means?
Well, COVID was a wake-up call. Yeah. Before COVID, the allocation to the health sector was far below what WHO and United Nations recommended. It's far, far below that. But in any case, the hospitals have kept on managing. We kept on trying to keep services running. But in actual facts, for us to run a tertiary hospital at the level we should, have those state-of-the-art equipment like your MRI, the magnetic resonance imaging, your CT scan, your fluoroscopy machine, mammography, laser surgery, do minimal access procedures and all that. We need far more than we're getting. And so when COVID came, and nobody could go outside of the country to get Medicare, it became obvious to us that we needed to look inwards and really invest in our health sector. That the government is doing now, and I can tell you, if you go around our tertiary hospitals, like teaching hospitals, federal medical centers, you will see the difference. A lot is happening right now. We are doing most of those things that are taking our people out of the country now are being done in this country. For example, at the Federal Medical Center, we are successfully doing hip and knee replacement surgeries. This is one thing that takes our people out of this country. Spine surgeries are being done successfully. Babies that were being born, premature babies at 26, 27 weeks, babies less than 700 grams, now survive in our hospitals. These are stories that can only be told in America. Oh, that I went to America to deliver, my baby was so small and survived. That if it was Nigeria, the baby would die. Now they survive here. Because we're not equipped. If you come to our neonatal care center and our neonatal intensive care unit, you will see the state-of-art equipment that government has provided. And so with that, we're able to do a lot now. Medical tourism is on the decline. I can tell you that for sure. And the reason is that government is now beginning to develop those capacities that were hitherto not available in our tertiary hospitals. We are not training our manpower, we're training some of these sent abroad, they train, and they come back to add value to what we are doing. We are not doing interventional procedures, we are doing minimal access surgeries, we are doing laser surgeries. That before somebody say, oh, I want to do cataract surgery, I don't want the open one, I want to go abroad, you just do laser, you don't feel anything. We can do that right now in our country. You want to do prostate surgeries, using laser, you can remove your prostate. Very minimal, you don't have those large scars that you used to have anymore. Your gallstones, your gallbladder stones can be removed without you having to have those large scars. These are capacities that are being used now in our hospitals. And it's thanks to the government. But we need to do this over a period of time before we can say, yes, we have arrived. It's work in progress. But I believe that the journey of 1,000 miles starts with a step, and the government has started that step, and we're in the right direction.
Okay, talking about manpower, we still know that when you get to the hospitals, the manpower are not there. Doctors are still not adequate.
Yes, doctors may be said not to be adequate because a lot are leaving the country, yes, in the system. But I'll tell you that as they're leaving, we have a program where we train and we replace those who are leaving. We have a residency program. I'll tell you, before this JAPA syndrome started, we had about 90 consultants at the Federal Medical Center. As of today, even with the JAPA, we have 110 consultants. And we are still appointing more. Because we have a training program, so as they train and they come out, we appoint them. So JAPA has not affected us so much because we have a program in place to replace all those who are leaving. Then when you talk about the other health workers, the nurses and all that, a lot of nurses are leaving the country, we agree. But you see, a lot more schools are also opening up. The minister said to us, we know people are leaving, there's a migration, mobility of labor. We may not be able to stop them, but we can do something about it to make sure we have enough to keep our service running, and let those going and be the export skills that we're exporting to the world. And in return, we get foreign exchange.
At our expense?
No, but we have enough to run the system. So that's what is happening now. You see, nursing colleges are being opened all over the places. We now have a nursing college, and we're producing nurses. So no matter the number that leave, we are still going to have enough to be able to salvage our system. That is the plan. That we should have a scheme where we produce enough that we can replace those that are leaving, and then those who are leaving become our exports. And in return, we're getting the high foreign exchange into our economy. So it's a win-win for us, the way I see it.
But looking at most of them that are leaving, there is this school of thought who believe that it is the best hands that are leaving. But the ones on ground, most of them don't even know their right from their left. Like in surgery, well, I'm not a doctor, surgery as simple as, though there's no simple surgery anyway. Yeah. There is surgery as simple as the appendix. That's a patient died. I think I saw that one when I was even in the hospital at that point. He said the doctor mistakenly cut off what he wasn't supposed to do that. A 15-year-old girl. I saw her because we were together in that
Don't believe all the stories you're told.
But she was my bedmate.
No, why I say don't believe all the stories you're told is that an appendectomy can be done by even a medical officer. You don't need to be a consultant to do an appendectomy. Okay. We have over 5 general surgeons qualified at the Federal Medical Center. So even those in quotes you say are very experienced hands are leaving the system. We have people who have been trained over time. By the time you have been appointed a consultant, you have attained a level of competence and skills that you should be able to do these basic surgeries. So to say a consultant did an appendix and cut off the ureter, these are not things that you hear about these days. They are not common. In those days, you used to hear that you go for surgery and you don't wake up. and it's still there.
Yeah.
You don't hear them anymore. You don't hear them anymore. We have anesthetists now who run the system. So you have specialists who do certain jobs, who specialize in certain areas. It's not a one-size-fits-all anymore. And so because of that, those kind of things you're talking about don't happen anymore. So there's much reduced. That's why I said don't take everything you are told hook, line and sink, and they just may not be true.
Okay. So you believe that with this machinery is in place, with this equipment in place, that the training and retraining of what the government is doing is enough to keep enough for us to have enough doctors in the country? Is that what you are saying?
Yes. What I'm saying is that with what we have in the tertiary hospitals, both teaching hospitals and federal medical centers across the country, we can afford to give quality training to our doctors, our nurses, and all our health workers. And so the issue of saying they are being not properly trained is not true. I'll give you an example. Our residents or our consultants live here today, they walk into the UK or walk into Saudi Arabia, pick up a job, and they are working excellently. They are judged as one of the best in abroad, in the US, in America, and Saudi Arabia. Nigerian doctors are judged as one of the best. Where did they get the training? Here in Nigeria. By the time they arrived in America, they had not done anything so different or so added so much skill to say that that's what is making them shine. It's the knowledge they got here. So our doctors are well trained, our health workers are well trained. And so when they go abroad, they excel. So I don't see why that same person who was working here before and
so they don't go for another training when they get there?
No, they go there, they join the job. Some are employed straight as consultants, some are employed as medical officers or resident doctors. They join the program, but you have the basic skills to compete with any other doctor from any part of the world. So there's nothing wrong with that training.
Okay, still on the issue of insurance, you just told us now that healthcare is very expensive. Looking at the NHIS scheme, most times you don't get the drugs. And for us in the Federal Civil Service, though the scheme now, the way it is now, anybody can access the health insurance scheme. Most times when you get there, the services are not rendered, the drugs are not there. Sometimes what you pay for is not what you get. Why is it like that?
Well, you all know that when you talk about healthcare financing, health insurance is the way to go, the world over. And so that is why Nigeria is encouraged. We are encouraging our citizens to key into the national health insurance. It is growing. We are improving on our health insurance program. And you can agree with me that if you go to get a service now at the Federal Medical Center with the health insurance, compared to what you will get 2-3 years ago, it is far better right now. The reason being that the scheme is being improved upon on a daily basis. They just reviewed some of the tariffs. Initially, when it was started, the tariff was low and remains still for a long time, but they are improving on it now. And so the services are better. You come to a hospital, you see specialists. If you were to pay for the services of those specialists, you pay so much. But for that little that government is putting together, is a pool and pulling together, you can have access to those specialists as many as possible. The drugs, you may say the drugs, all of them are not available because they may be very expensive. But the basic ones are available. Some of those expensive ones are not covered.
Why? But why is it so?
Yeah,
for every month they deduct from one's salary.
Why I'm telling you is not covered is that health insurance, national health insurance does not pay for all categories of treatment. There are some not covered. For those that are covered, we are encouraged to use generic drugs. But right now, you know the situation in the country. The so-called none of the drugs are cheap. Even the generic ones, they're not cheap. So when you get these drugs in and you administer, they expect that when they're giving prescription, they should get everything they want.
Yeah.
But given the cost, when you look at the cost and the program the way it is running, it's sometimes not very easy to make all of them available. But quite a number of them are available when you come.
Okay, let's take a break. We'll be right back. The program is still Standpoint. Standpoint is an incisive and impactful program that gives an overview on how personalities shape the society, Join us every Tuesdays from 10 a.m. to 10:30 a.m. on NTA Asaba, the station that adds value to society. It is hot, frank and engaging. Standpoint, standing for stardom. Welcome back. The program is still Standpoint, and my guest in the studio is Dr. Victor Azubike Osiatuma, the MD of the Federal Medical Center. So let's look at lack of supervision or carelessness or misdiagnosis, supervision or carelessness. This has to do with a particular patient dies in the hospital without the doctor, without the nurses knowing that this particular patient is dead. Or let's look at another scenario where this particular patient is suffering from SYS issues, and they will now recommend another treatment for that person. By the time they get to know that this is what is supposed to be, it is late.
Well, if I get you correctly, you may be talking about misdiagnosis.
Yes.
Or you're talking about medical negligence. I want to put it this way. You know, when people talk about medical negligence, most times when you look at it, the story is usually blown out of proportion. I'll give you an example. We are a tertiary hospital, the Federal Medical Center. There are different levels of care you get. If you come into the hospital now, you have the house officer, you have the registrar, you have the senior registrar, you have the consultant. It is difficult to say you are admitted into the Federal Medical Center and none of this category of people have seen you. It is not true. But you know, most people come in with the impression that when they are seen by a house officer, they say, oh, these are students, doctor never see me.
Yeah.
Do you get it?
Yeah.
Now, a registrar will come, see you, do all what he needs to do, report to his consultant, he's in touch with his consultant, and action is being done, and they tell you, nobody don't come see me today. I have had cause to interrogate on several occasions. And I got there, and I looked at their case note. The house officer has seen, the registrar has seen, senior registrar has seen, and I asked, I said, madam, but these people that wrote all this, did they see? He said, hey, they come home. But this one are students now. I never see the big doctor. That is a wrong impression. A senior registrar is just a few months short of being a consultant. He's as competent to see you as any of the consultants. So when he comes, he sees you, he does not take the decision alone. He gives a feedback to his consultant. Even the consultant is not there physically, he's aware of all the patients he has. Even during call hours. During call hours, you have first on call, the house officer, you have second on call, the registrar, you have third on call, the senior registrar. They're all sleeping. The consultant doesn't sleep in, but he's given a detail of everybody going on. But the impression generally, I've been here 2 days, so nobody don't see me. But when you go there, it is not true. You're on medication, the doctors have come, they've seen you, they won't take time to explain to you your condition and what they are likely to do to you. But as far as they've not seen if he needs to go to theater, he's not in the theater yet, or he needs any intervention and it's not been happening immediately, because nothing has been done to him. So the issue of medical negligence is not as they paint it. It is not always true. I've had to investigate it severally, and I can tell you.
Yeah, but sometimes it does happen.
Yes, it does happen. It does happen. And when it happens, and we find out where that gap comes from, we'll deal with it. We have an internal mechanism, an audit system, where we audit the process. So if you stay in the hospital for 2 days, you were not seen, and we find out, we must know what happened. We must find out what happened. But it is rare. As we speak today, we have not less than 350 doctors in that premises at the Federal Medical Center. To say that government is not providing enough manpower will not be true. We have close to 700 nurses in that hospital. So the last thing you come to the hospital and you're there for 3 days, nobody is seeing you, it's not true. Because I have investigated several and found out those information are blown out of proportion.
There is also issue of misdiagnosis.
The issue of misdiagnosis. Well, you could say a few times there have been issues of misdiagnosis. But I tell you what people call misdiagnosis. In a tertiary hospital, you don't just start treatment. You come in, you may take a week investigating you. That's why it's a tertiary hospital. Sometimes you've gone to 2-3 different hospitals, you've gone to a general hospital, you've gone so many, and nobody's sure what is wrong with you, and they send it to us. And then we now start to go through our series of investigations before we arrive at a diagnosis. While all that is going on, the patient believes nothing, as long as they are not pumping you with drugs, they are not doing anything else. They never do anything for me. But all what we are doing is to investigate. Drug is not food. You don't just dose people with drugs. You must have a working diagnosis, something you are about to treat. So until you get to that point where you've made a diagnosis, you cannot start treating. Now, we had a patient who came in with very low blood volume, low PCV, and they managed him transfusing in the peripheral hospital. They just come, they give him blood, he goes home. After 4 weeks or 5 weeks, come back, the blood is low again, they give him.
Why?
So after, nobody is thinking about what the cause is. They just come, they treat that symptom, you go. And then he was referred to Federal Medical Center. And the hematologist takes his time. And that starts. He does the bone marrow, he does the full blood count, he does deep analysis of the blood cells, and he's taking his time to arrive at the diagnosis. We may be dealing with a leukemia, but you need time to make that diagnosis. And the patient is impatient as far as it's concerned. I've been here, they're not giving me blood like you give me, you're slow, so nothing they happen. But that's the tertiary hospital. You don't just come there to be dosed with drugs. You come there for us to find out what is wrong with you. When we find out that thing that is wrong with you may be genetic, it may be familial, it may lead us to having to look into your family that you come from, to save others who are not having the symptoms yet. But people are not patient most times. They want to just come in immediately, and by the next day you jumped up, but by the time you are coming to a tertiary hospital, your case is not malaria and typhoid. So you can't be jumping in the next day. You may need processes. You may need surgery, you may need, and that is what people are not patient to do.
Okay. You have been the MD since 2017 at the Federal Medical Center. Is it the federal government that is funding those structures, or it is the Federal Medical Center itself that is sustaining the structures?
Well, like you read in the book, you were doing an analysis, you saw that there's money voted for the health sector. And when you look at the budget of the health sector, you have what is called the personnel, to pay our salaries and allowances. You have the capital vote. The capital vote is meant for those structures the same, to build structures, to equip the hospital, and all that. And then you have an overhead. The overhead is for your daily running of the hospital. So from that capital vote, the hospital prioritizes its needs. When I took over, our immediate need was space. We had space challenge. We wanted to expand. We didn't have space where the people we were employing would stay to do their job. So we decided to provide those spaces. We got accreditation of the house officers. It was compulsory we have a quarter for them where they would stay. So we embarked on building house officers' quarters. We have provided about 80-bed apartment now. So right now we're training about 80 house officers. We're training over 200 interns. We still need to provide accommodation for them. So it's ongoing. We started looking at the wards. We didn't have enough wards, we had to build more. We didn't have enough theater spaces, we had to expand our theater spaces. We didn't have enough clinic spaces. We were developing more subspecialties, ENT, neurosurgery, ophthalmology, and all of that. We needed spaces for them. And so that's why those buildings are coming up. But predominantly, the bulk of the money used for those structures are coming from the Consolidated Revenue Fund of the government. It's coming from the federal government.
So the journey so far, just tell us how has it been for the past, how many years, since 2017?
8 years.
8 years now, yes. How's it been?
Well, it's been a worthy experience. For me, it's been an opportunity, a very rare opportunity to serve our nation. And I'm very grateful to His Excellency, the President of our country, for finding me worthy and putting that trust in me.
More tax ahead for you.
My first tenure, and I was given a second one, and I'm very, very grateful. Over this period, we've been able to improve the health indices of our people. This is the only federal tertiary hospital in the United States. And so you expect that a lot of activity, a lot of referrals will come there. From even neighboring states, it's easier to refer a patient from Onitsha here than referring to Newi or Enugu. So a lot of them come here. And so we've been a pivot, we've been a rallying point for a lot of them, And so we've been able to expand our services to include those things that commonly take our people out of the state, maybe to UBTH, to LUT and all that. We never had neurosurgeons before. Now we have neurosurgeons. We have successfully removed several brain tumors in the hospital here. Before now, you have to go to UCH to do that. Now we have trained our consultants. They are doing well. We are removing them. you have hemorrhage now, and there's an accident and there's bleeding to the brain, you don't need to run anywhere. We'll take care of it here. So all of that has been a good experience for me. We've been able to develop capacity. We've built a lot of manpower from scratch. I said we have about 110 consultants. More than half of that number were trained here in Asaba.
Beautiful.
Most of the other people you see running the other hospitals around, we're also trained here. Interestingly, the CMD of Asaba Specialist Hospital was trained in FMC Asaba. They also tell you what we've been contributing and what it's been like. So for me, it's been a worthy experience. I'm very grateful for the government for giving me this opportunity. And I want to say that we have served our nation well, and we believe that we have helped to reduce medical tourism and contribute to improvement of our health sector.
Thank you very much, Dr. Victor Satima. It's been a pleasure talking to you. As you round up the headship at the Federal Medical Center, it is my prayers, our prayers here in NTA, that a better tax will be given to you. Because we know when you started, we saw the structures there, and we could tell for sure that yes, there is great improvement there. Thank you for making yourself available to serve.
Thank you so much.
Thank you so much.
Thank you
The program has been Standpoint. Same time, same station next week. Good morning. Standpoint is an incisive and impactful program that gives an overview on how personalities shape the society. Join us every Tuesdays from 10 a.m. to 10:30 a.m. on NTA Asaba, the station that adds value to society. It is hot, frank and engaging. Standpoint, standing for stardom.